and running. Okay, so with that said, Dr. Wilds.
All right, good morning. Before we get started, Dr. Koshy kind of reminded me of something for anybody that would be interested. So if any of the interns are interested in doing fellowships, we have kind of a little group that we've put together where we meet a couple times a year, and we have strategies to kind of beef up your CV to make you more attractive to applying for fellowship. So it doesn't necessarily have to be cardiology, although that seems to be more what we're heavily weighted on. But if you wanted to do GI or something more competitive, then I talked to Dr. Koshy. We're going to have a date where we'll get together, probably October, November, and we'll kind of show you what you're up against and give you things that might be useful and making you more attractive as a candidate for a fellowship. So this morning, this is kind of for the interns. You know, a month ago, nobody really cared how much you do. You kind of wandered around and maybe did some notes and you could answer some FIM questions and all of that. Now, all of a sudden, 4 weeks later, you're kind of on the spot. People expect you to know things and know how to evaluate things and take care of them. So there's, you know, the first couple of months of residency are a little bit stressful because you have a lot of the knowledge, you have minimal experience, and you kind of need to use your knowledge to expand upon that, and then also to provide good quality care. So chest pain is one of the most common diagnoses that you'll see. How many times on internal medicine, another chest pain rule out. But actually, you truly can learn a little bit of something from every admission. So maybe you can think about something you hadn't thought about in a while, or maybe it's just a matter of getting more efficient with doing your H&Ps. Remember, as a student, it might take 2 hours to do an H&P. As time goes on, especially in practice, you're not going to have 2 hours to do that stuff unless you want to work till midnight. But learning how to be efficient is great. We're going to focus on pearls and things that would be useful in practice. So the causes of chest pain, there's a million. We're going to focus more on the things that are going to be more likely life-threatening in the acute term. So a lot of this would kind of focus to how are you going to survive at night and not hurt anybody. So cardiovascular causes, obviously, we're worried about acute coronary syndromes for the most part. There's pulmonary causes. PE is kind of a big one. But you see there's a big long list of other pulmonary things. GI. So you see these rule outs. About 70% of the time, if chest pain is not cardiac, it will be GI. So there's a big long list of things there. It could be musculoskeletal. And I meant to look this up, Bornholm disease. I'm not sure what it is, but it doesn't require stents, so I'm a little bit less interested. But then, you know, psychiatric things, panic attack, anxiety, or maybe they're just all out crazy, you can't tell. And then a handful of other things. So out of all that list, what do you really need to know? So when you're seeing somebody, so when your senior tells you at night, the ER calls and says, I have chest pain, come do this admission. What do you really need to know? There's 3 things not get burned on. These are the people that will have poor outcomes if they're not treated appropriately in the short term. So obviously MI, don't get burned on pulmonary embolism or aortic dissection. Most of the other things can survive a night, and if it turns out not to be MI, you can look into other things and you probably haven't lost anything by sitting on them all night. So a little bit about pulmonary embolism. I'm not going to go through all of these things. Most of this is going to be a little bit interactive, just warning. So I'm going to need a little bit of participation because we're all kind of learning how to think is kind of the big thing. You can read all this stuff at your leisure, and you probably had lectures just dedicated to pulmonary embolism. But just kind of a review. It may or may not be sudden onset. So dyspnea, tachypnea, could be pleuritic kind of chest pain. Rarely you'll see hemoptysis. sometimes cough. You can have signs of hypoxia. Then physical exam may or may not be that helpful. It's kind of interesting here. So if you want to diagnose RV strain on physical examination, you're going to look for left parasternal heave, allowed P2, elevated JVP. That you may actually be able to see. This is all for boards. They will give you questions on boards about loud P2. I don't know anybody that is that good at physical exam where they're going to be able to turn that out and they're going to examine somebody and say, oh, this is PE. There's probably some of the older guys, but older than me even, that may be good at that. So if it's in the back of your mind, if it's a thought, I would encourage you to go through some steps, because it is one thing you don't want to get burned on. And this is one thing they don't pick all of these up in the ER. A lot of them, there's any doubt, they will get a CTA and they'll find it. But, you know, from time to time, we have some of these that end up getting admitted, and, you know, they may have troponin elevation of 3 or 4. And we had one a few weeks ago where somebody had syncope, which is a high risk finding in PE, that had a troponin of 4. And because we're cardiologists, we think of the heart. And so he got a heart cath and there was nothing on there. We thought, well, maybe we should just check for sake of completeness, we'll rule out PE. And sure enough, he had PE that could have easily been missed. But you guys are probably all familiar with that, the well score. So here are kind of the things that you guys might be missing a little bit just because you're just starting off. I mean, alternative diagnosis is less likely than PE. So this is kind of experience. What's your overall impression of the patient? If you think there's likely PE, somebody that has cancer and he's had, you know, heart rate's high, you can't really explain it, and maybe he's a little bit short of breath, doesn't sound overly impressive. And then obviously, if you think they have DVT, a lot of times that could be found on exam. So then they have, you know, this score, you know, high score. You're going to evaluate, or maybe just put them on treatment until they can get CT scan or VQ or whatever you're going to do. But really, in a practical thing, if you think there may be PE and you're not sure if this is the ischemic chest pain or not, just scan them if there's no contraindications. Because that's something with poor outcome if we don't treat it. The other, aortic dissection. So just a minute on this. So most of these are going to be caught in the ER. So these are people, this isn't missed that often, but it can be. But these are people, usually the pain is pretty significant. So they're kind of writhing in pain, and it's more of a pain in the back and tearing. And this is another one you'll see in the ER. If there's any real suspicion, they will just get scanned. And that's probably a good policy. But so as opposed to ischemic kind of chest pain, this is going to be more severe. It's less likely to be like the heaviness or that kind of thing. So you look for the unequal pulses and those kind of things. All right, so now for cardiac chest pain. One of the things you want to do as you see these is kind of think in your mind, is this a low risk patient or high risk? You know, for me, it's a little bit easier. Presumably, I should know what I'm doing by now, but experience actually is something that's valuable. So a lot of times I without going through any of these risk scores, I'll have kind of a good idea whether or not I think there's a significant chance of ischemia. But I will tell you, in private practice, we got every chest pain was admitted to cardiology, and a lot of these really didn't sound like much. But sure enough, once or twice a month, someone would bump their troponin. So turns out it was a good thing they were there. There's a bunch of risk scores that you could use. Common ones are the TIMI risk score or GRACE or the heart score. Now this could be a whole lecture in and of itself on how to how to risk stratify people and what this means and how do you treat people based on risk. But I'm just putting this up for a couple of reasons. One is it may be good when you're starting off, and it may be good practice for everybody to do it, even though we really don't, because it's cumbersome, and you know what, we have all kinds of other things to do, and sitting and adding up all these points seems to take a little bit of time. And there've been studies on that, so an experienced clinician is not going to be helped that much by these kind of scores. Because if I have somebody with a low score and I just don't feel good about it, I'm going to be more aggressive. Or if you have somebody with, really high score and, sometimes you don't think that much of it, maybe you'd be a little bit less aggressive. But the history is going to be very important. And that's we'll talk about that a little bit in EKG. And then age over 65, because a lot of people over 65 have coronary disease anyways. And then you'll look at the traditional risk factors and troponins. And that's the hard score, the TIMI risk score. They're all kind of similar. And all these were done in the setting of in the setting of studying some drug. So they're actually fairly well validated. There's some pretty big studies. And you look at these things here, same thing. So the key with aspirin, and I didn't know this for a long time. So I'm going to try and give you pearls of things that I didn't know for a long time that I should have. So I just thought, it didn't make sense to me. Why would you penalize somebody for taking aspirin? So really the theory is they're getting chest pain, or you may have an acute coronary syndrome despite the fact you're on antiplatelet therapy. So that would place you at higher risk. And then you see that, the symptoms, EKG and biomarkers and all that stuff. And then you see the traditional risk factors. And you look at this, and one thing to keep in mind also, when you get angry at the ER for sending stuff up, because you think this is clearly not cardiac, they're wasting my time. I have 8 other HMPs to do. But if you see here, it's a risk score of 0 to 1, you have 4.7% risk of at 14 days of all-cause mortality or MI. Or ischemia requiring urgent revascularization. So a lot of those that could be sent home from the ER actually it's not zero risk. All right, so now the history. And you guys all know this stuff, but now it's kind of time when it's a little bit different when you're wandering around and you have a resident with you and they kind of make all these decisions and everything kind of makes sense. And that's why on rounds, I try to let everybody present things, because it's easy when someone else does it, and then all of a sudden you do it, and you fumble a little bit, and you're not really sure. That's only normal, but it's time to kind of bring all this stuff home. So the characteristics of cardiac chest pain. So we can see somebody in the ER with big anterior ST elevation, and obviously their whole anterior wall is melting away in front of you as you talk to them. And they may argue that it's not chest pain, it just feels like tightness. In contrast to the aortic dissection, those people have pain and they're getting narcotics and they still don't feel better. But it's going to be a pressure, fullness, burning, tightness. And sometimes you see radiating to the back or to the jaw or shoulder is fairly common. We saw someone yesterday that came with an abnormal stress test, and he's complaining of pain in his shoulder and his neck. And for us, it was concerning because that's the same symptoms he had before he had bypass. So not everybody, some people just get jaw pain. Sometimes you'll see that. So always beware of diabetics, because they're going to have different symptoms, and old people don't have the same kind of symptoms necessarily either. So if the pains last for more than a few minutes, but if it's worse with activity, then everyone makes fun of me because I'll ask people what they're able to do. So for one of the things for stable ischemic heart disease, people with arteries that are blocked 60, 70, 80% that don't have a lot of symptoms, I'll always ask try and get an idea what kind of functional capacity they have. So if you can climb up 3 or 4 flights of stairs without chest pain, that's probably a good prognostic indicator. But if you're getting heaviness when you walk to the bathroom that goes away when you rest, that would carry a much worse prognosis. But it can be, sometimes dyspnea can be an angel equivalent. So you have to be aware of that. And then you see this diaphoresis, and it could be dizzy or weak, and that might make you worry about arrhythmias or something. Nausea or vomiting sometimes can happen, and that happens frequently when we see infarcts of the right coronary artery. So you might lean more towards non-cardiac chest pain. If the pain's reproducible, then it's probably, you can't reproduce cardiac kind of chest pain except potentially by activity probably. So if it's been there for hours or days and they still have normal troponin, then it's not likely to be, it's almost certainly not cardiac. So these people that get admitted with 3 days of chest pain, maybe they don't need to be in the hospital. But where you're kind of at a disadvantage, well, they came to the ER, it's been there for 2 or 3 hours and you're not really sure. But if they've had pain all night and they have normal enzymes, then you got lucky and it wasn't an MI. And then obviously pain that's kind of positional or symptoms of reflux or pleuritic pain. So sometimes you'll see this a lot in clinic in people that have sharp pain with deep inspiration. All right. So with those things in mind, you're called, your patient's here. So what do you do? What do you do when they get to the floor? So you've done the history, you've made kind of an impression. Is this likely to be, not likely, highly likely, or most of them will be kind of in the middle. So everybody should get aspirin, unless there's some contraindication. Like what? What would make you not give aspirin? Allergy. It's got to be a pretty, so allergy is something for every medicine. If you think, aspirin has mortality benefits, so you want to be aggressive about giving it if you can. So sometimes you'll see allergy, that's listed on their list of 15 allergies, or it may be only 1 or 2. You got to make sure that it's really truly an allergy. So is this something, because a lot of people will just be an upset stomach, or they had a GI bleed years ago and someone told them you can't take aspirin anymore. Versus somebody that has hives or anaphylaxis or something like that. Then obviously those, especially if you think it's an acute coronary syndrome, it's probably not a good idea to challenge them and see if that's really true. All right, so other antiplatelets. I should have put this a little more toward the bottom of the list. So if you think this is an acute coronary syndrome, and so you'll see the chest pain rule out. So you're assuming they have acute coronary syndrome until proven otherwise. Because that's what's going to kill them. Assuming you've excluded PE and dissection and all those things. So really, if you look at all the guidelines, these people should be on P2Y12 inhibitors. What are those? The Plavix or Effient or Brilinta, right? And what is the problem with those? So in my mind, and it's because we're thinking 3 steps ahead, not just 1 step ahead. You got to think 3 steps ahead. So what can happen sometimes is, so they have a troponin bump and they get a cath the next day. Now they've been loaded on this, and now if they have 3 vessel disease, you're kind of in trouble. What do? So then you're going to have a surgeon that's kind of angry. Why did you give this? Now I have to wait 5 days before surgery. So personally, I'm a little bit reluctant if it's lower risk. I think if it's that high risk and they're still having pain, they get a cath. I don't care what time it is. They'll come in at midnight or 2 a.m. and we'll do that and we'll find out for sure. But once you give this, you kind of poison the platelets, and now they're stuck waiting for 5 days, which becomes 7 or 9 days, and that's kind of problematic. So then the other thing, so antithrombin. So everybody, mostly we use heparin, which is fine. So how do you know who you're going to start on heparin? No volunteers? So 0.4 or higher. What if, all right. So if it's not 0.4, then you're just not going to put them on heparin. Yeah, then you're going to put them on. So if you think that you're treating for ACS really. So most people are not going to be harmed by heparin. Just give it or Lovenox. That's in private practice. It was nice. You just give them a dose of Lovenox. They'll be protected overnight. Then we'll come see you in the morning and see what's going on. So unless there's big contraindication, then I would use that. I would just stick with these two, heparin and Lovenox. Maybe you'll read something about Fondaparinux or something else. I would just stay away from those for various reasons. All right. So what about nitrates? When do you think about nitrates? Does that benefit everybody? What's the mortality benefit with nitrates? Anyone know? George? There's zero. Nitrates have never saved anybody's life. So all that stuff you see on TV, they've got this severe pain, crushing chest pain. They take nitroglycerin and all of a sudden it's saved their life and they're going to do fine for another couple episodes. But if they're still having pain, certainly you could use nitrates. So there's really two flavors. You can use, nitro paste, which I don't know. To me, it's a little bit better than placebo, probably. I'm not. If I think it's ischemic, don't wait. Don't mess around. Put them on something that's going to work. So I would put them on a drip. If they come up from the ER with nitro paste, that's fine. But don't forget Viagra, Cialis, and those things. Because those, you will see people that have taken that, and I would ask, because that can be bad news if you put them on a nitro drip and they've taken that within the last 24 to 48 hours. All right, so narcotics are your friend. That will help, especially if it's non-cardiac chest pain. I mean, definitely don't overdo it. You want them to still be breathing when your attending comes in the next day to round, but that can help with pain relief. And then you have to determine, are you going to give beta blockers? Should you give everybody statins? There's probably some benefit to giving upfront statins. It's probably not going to hurt anybody. So that's the one thing. What can I do that may help and not likely to hurt someone? So beta blockers we'll talk about in a little bit. All right, so the troponин's okay. They're on the floor and they're still having maybe a little bit of chest pain. The troponin's fine, so you're okay, right? The one thing to keep in mind, and this is so funny, it'll be in the cath lab with a STEMI and the lab will call, troponin is 0.03. That's of no help. That's arteries occluded. So you see in the first several hours even, the troponin is going to rise slowly. So it may not be, even in STEMI, if they came quickly, it's likely to be normal. So if you wait and let them sit on the floor with chest pain for 12 or you're going home because you're done with your shift at night and now they're still having pain and the troponin is 40, you've not really helped the patient that much. And this is kind of interesting here. I haven't seen this before, but if you'll see a high peak. So if somebody comes in early, we put a stent in, the troponin peaks quickly and goes down quickly. And I've seen this in practice. So if there's something that can't be fixed or they elect not to have PCI for whatever reason, the troponin will go up slower, but look here, it doesn't peak for almost 72 hours. So it just seems to rise slowly and it'll be around for a lot longer. All right, so keep that in mind. So they may not be in the window where the troponins will be abnormal. But remember, we talked about somebody that had chest pain for 3 days, that troponin's going to be high for sure. I mean, definitely within 12 hours, you're going to see like fairly high troponins. And they have ultra sensitive troponins that can be positive even within a couple hours. All right, so now we get into the meat and potatoes, and this is probably going to be a little more interactive. So I'm giving out some of the answers. So now they're on the floor, they're still having chest pain. You've not gotten rid of it. So you have to assume if they're there because you think it may be cardiac chest pain, If they're still having pain, then you're melting away heart muscles. And that will continue until you do some kind of intervention to get rid of it. So if it's, if it's a 95% stenosis, it's not really STEMI yet, you may be able to give a medicine and get rid of that pain. If it's totally occluded, the only thing that's going to get rid of that pain, there's two things. One is PCI, and that's what you would want. The other is it'll infarct, and after a couple of days, the pain will be gone. And that's what we're trying to avoid. So probably the best thing you could do is get another EKG. So sometimes you'll see kind of non-specific things, or maybe it looks like there's maybe a little subtle ST changes somewhere. If they're having more pain, get another EKG, because sometimes you can unmask a STEMI. Sometimes the second EKG will look a lot worse. And then think about it. Does it really sound like it's cardiac? And this is kind of where you guys are a little bit of a disadvantage, because you're still trying to, still kind of getting experience. And this is where it could be a little bit scary. If you're on the floor by yourself, you're the one that's, now you're a doctor. You're not a medical student anymore. You have to, this is your responsibility. This is somebody's grandmother you're up there taking care of. So do you really think that it's, cardiac or not? So you want to make them pain-free, and that's something that not everybody is aware of. I remember even when I was an intern, I thought, there was somebody in the ICU that had chest pain all night long, but it wasn't that bad, and someone kind of sat on it and thought they were doing reasonably okay. And these cardiology fellows came in and they're like, oh my, she's never been pain-free the whole time. And they use that as kind of they were not easy to face when something didn't go the way they wanted. But I'm looking to, we used to carry, we didn't have iPhones in those days. So everybody had all these books. So I'm looking at the book, well, he's on everything. He's on all the medicines. What else are you going to do different? So really, if they're still having pain, that's a problem. And if you can't get rid of it, then you let somebody know. But you want to control the blood pressure. So blood pressure, if your blood pressure is 200, that may cause chest pain by itself, right? So you want to make sure that that's at a reasonable level. And I don't have like exact answers. I would not try and get it to be, 120 overnight. But another pearl is, that all your admission sets have troponin every 6 hours times 3 or whatever, right? You don't have to wait 6 hours. So you remember how that graph, you see how the enzyme levels will increase. Don't wait 6 hours, get another one in 1 or 2 hours. And if it's going up, then that's a problem. Then you need to let somebody know, and that can be addressed. So if you're really astute and you're good at all this stuff, they have all those ultrasound machines here. You can do that at the bedside, and sometimes the pictures are okay, and nobody would expect you guys to be like adept at that, because they're not always easy to get decent images, and it takes a little bit of time to learn how that works. But that's a good way too. And a lot of times in the ER, they will do that because they're pretty good with the ultrasound there, but sometimes they're a little too busy to use it. Then if in doubt, just keep the patient NPO. The next day, you're probably going to do something, right? You can't do anything. Can they do a chest x-ray if they're not NPO here? I'm not sure. Everything has to be NPO. Stress test or NPO for some reason, but definitely for cath. So that's one of the things where, something doesn't sound really overly concerning to the resident, and then we come the next day, well, they can have cath. Nope, they've ate breakfast, so you can't do for like 14 hours after that. So a lot of times that increases the length of stay. All right. So besides the history, the next most important thing is going to be the EKG. So we have a couple EKGs. Anybody want to tackle this one? So let's focus on ischemic things. There's no tricks here. I don't care about hypertrophy or the rhythm or any of that stuff. It's not a trick question. V3 and V4. Yeah, that's probably normal. So you got this person, they've got this severe chest pain, sharp stabbing. They're breathing 24 times a minute. You see this EKG every day. The diagnosis starts with N. Normal. Well, not everybody's going to come with, people are going to come with normal EKGs, believe it or not. So you have to be able to know what's normal and what's not normal. And the only time you might get burned here as far as acute coronary syndrome is if you have occlusion in the left circumflex system. That's in the back of the heart, so that's kind of electrically silent, right? So if they still have this crushing pain that, you know, maybe gets a tiny bit better with nitrates and you're not really sure, then, you know, then you're more suspicious. But if it's sharp stabbing pain and they're anxious and they have this EKG, then that's reassuring, because the EKGs were on all those kind of risk scores, right? All right. So what about this one? Because this is important to recognize too. It's not normal. Anterior STEMI. Well, that's in the differential diagnosis for sure. So I'll help out a little bit. So what you would expect to see, you would expect to see reciprocal changes, which we don't see. Everything else looks okay. What if I said that this is a 25-year-old African-American male who with pericarditis? Well, that would be the differential too. But maybe you would see more widespread ST elevation, PR depression. So he's here because he had a cough and he got his obligatory EKG and chest x-ray. So this is a normal variant. So this is early repolarization. See how you have the J point elevation and concave, kind of concave T waves. So this is more common in younger people, more common in younger males, especially African-American males. No reciprocal changes. You may see that's on the floor, something that sounds ischemic, and you might see that EKG. I'm sure people have gotten cath for this kind of EKG. All right, so another example, chest pain EKG. This is someone that has significant pain and you're having a hard time getting rid of it. Nitrates does nothing. Doc, you got to do something. This is right out of the book. Okay, that's a good answer. So why it makes you think pericarditis? PR depression. We just talked about that. Good. All right. Okie doke. Okay. Now you have this EKG. All right. Someone over here. Shafiq, help him out. Yeah, so there's ST depression across so these are across the anterior precordial lead. So this looks more like ischemia. So this is the kind of, you get points on this from the TIMI risk score or the heart score or whatever. So that one's a little bit more ominous. So if they have this kind of chest pain, you really want to be aggressive about giving them something that's going to take the chest pain away, beta blockers or nitrates or whatever. And you may see as the ST segments get better, then their chest pain gets better as well. So that one you need to keep your tail up. make sure that you get that, the person with that EKG, make sure you're doing something for that. All right. This may be the last one. This is an intern one. If you guys, you have this, come up to the floor. Here's your second EKG. You're there all by yourself. And maybe they're not feeling that bad. It's just somebody with indigestion. What's the diagnosis here? George, inferior wall MI. And what makes you so confident that's what it is? So right here, so these are inferior, that's inferior ST elevation, good. Then you see also kind of posterior, you see this ST segment depression, so that's probably inferior and posterior. Good, all right. All right, we got that out of the way. So we need more work on EKG. So that's one thing that you have to be pretty confident about. Does EKG normal or not? You can look at the top of the EKG, it's right 70% of the time. And the doctors are right about 70% of the time. So we'll miss about 30% statistically. All right, so everybody here knows what medicines you're supposed to do. So you have the one, you have somebody, let's focus on somebody with this EKG. So they have ischemic EKG, they're still having chest pain. What's the first drug you're gonna get? So you can have beta blockers, ACEs, ARBs, calcium channel blocker, nitrates. What's the best anti-angio medicine? Beta blocker, good. All right. You guys are letting a medical student outdo you? I would. Let's have some competition. All right. So how much do you give? Because you see in a book, you'll see that 25 milligrams to 200 milligrams, how much should you give? And I will tell you that one thing that's common when you're just starting residency programs, you're a little bit scared to give too much because what'll happen, and it's good to have a little bit of fear, but you need to use solid doses for this kind of stuff. So you can use, so beta blocker is going to be your first line agent to get rid of this chest pain. So you want to get the heart rate in the, between 55 and 65 is cardioprotective. So if it's 55 and it's time for their next dose of beta blocker, the nurse calls it, well, they're bradycardic. What is your answer? That's okay, give it, that's what's helping, that's where you want the heart rate. All right, so you can use metoprolol, carvedilol, those are probably the most common. So for acute coronary syndromes, there's no advantage of one beta blocker over the other. So, the old days you used atenolol a lot, you could use bisoprolol or whatever, but these are tried and true, and it's good to pick one or two medicines from each class and be comfortable with those, and you'll kind of know what happens with your doses and all of that. Metoprolol is very inexpensive, but both of these are very inexpensive, so that's nice too. All right, so how much beta blocker do you give? How much metoprolol? Say you want to use that. 50? All right. The blood pressure was 90. You just gave 50 of metoprolol. That's okay? Yeah, well, all right, good. I like that. That's true. I probably wouldn't give 50 if the blood pressure is 90. So you want to know how much, what are the vital signs before you start, right? So if the blood pressure is 200 and you give 25 or 50, that's probably not that much. I mean, I would be cautious, to be honest, giving 100 milligrams all at once, with even with a blood pressure of 180, something like that. But these aren't you're right, that's not a very powerful blood pressure medicine, so not likely to lower it that much. It's a good AV nodal blocking agent, so that's going to help lower your heart rate quite a bit. So it depends on where the baseline blood pressure is, baseline heart rate. So you need to know all those things and kind of keep that in mind. And then you also have to think about contraindications. What's like the couple of biggest contraindications for beta blockers? They're on Viagra. Well, boy, I'll have to look that up. That's probably more nitrates you're thinking. But I appreciate you speaking up. But I think you can give beta blockers. Well, you can give beta blockers with Viagra. So what else are you going to see? So you'll see in some of the guidelines, or you'll see these little things that you read. Someone's coming in with MI. When do you not give beta blockers? COPD, cocaine. Yep, that's a good one too. Potentially, I'm not sure I believe that, but that is in the book. I see plenty of people that use cocaine or meth and don't have problems, but don't give it until there's a randomized trial. I would shy away from it, and remind me to get back to that in a minute. So if they have COPD, so beta blockers potentially a mortality benefit in acute MI, right? So if they have COPD, you're going to withhold it? Not all the time, right? So if they have active wheezing, definitely don't give it. If you use the advantage of metoprolol, that's beta 1 selective, so less likely to cause wheezing, especially at lower doses. Once you get more than 75 or 100 milligrams, then that would be a problem. So you would not do it in somebody that's actively wheezing or had intolerance, or if you're not sure, then maybe I would shy away from it, because you don't want to set off, if they're having acute coronary syndrome, you don't want to set off wheezing and make them less stable. So carvedilol, that one is a nice one. So if the blood pressure is higher, I would probably use that. So if it's a blood pressure of 180, give them a good slug of carvedilol. Now you may see somebody on the floor that fairly high blood pressure, tachycardic, chest pain. It's okay to give some IV low pressor. That's fine too, especially in the ICU. I don't know if they would. Is that acceptable on the floor or no? It is. What's the dose of IV low pressor? 10? Yeah, you're thinking, well, I like the way you think. It's aggressive. Probably I would stay with 5 and see how they do after a few minutes, and then give another 5, and you can, that used to be actually, in the old days, there was a study, the Miami trials, that showed everybody that had STEMI got IV low pressure. So they give 5 milligrams every 3 minutes. And that showed benefit. There's been some studies that show that it's of no benefit. All right, so carvedilol, what is going to be the dose on that? So it depends on the blood pressure. Say blood pressure is 160, how much would you give? And this is not in any book either, so this is just kind of experience. So it comes in 3.125, 6.25, 12.5. Say 160. So yeah, that's probably okay. I would try to, so if they're otherwise stable, don't get the blood pressure from 160 to 120. If it's 150 all night long, that's probably okay. It's the long-term effects you worry about for high blood pressure, right? And that's what's going to cause chronic kidney disease and heart failure and increased risk of strokes and all that stuff. If they're 150 all night and they're feeling okay, that's probably okay. I'd rather have that than have 120, and now you get more ischemia because you still need to perfuse the coronary arteries. All right. So enough of that. But you'll get more used to giving. You'll get more used to getting comfortable with doses as time goes on. But you have to find that kind of fine line with giving enough without giving too much. So there's really no place for ACE inhibitors or ARBs in acute coronary syndromes for the most part. So if they've had MI and they have low EF, then you're going to put them on something. But I bring this in because of, so if you have somebody with the blood pressure is 200, and so their heart rate is 60 now, and And what are you going to do? What are you going to give them next? And this one, something out of these may not be a bad option. So one pearl is, and this is something that this is the medicine nobody uses. If you have a blood pressure of 200 and you want to get it down reasonably quickly, you can give them oral captopril. That works very quick. So give them 50 milligrams and that'll bring it down nicely. So lisinopril is going to take a little bit longer, or any of the other prils aren't going to work quite as fast. I don't know. I suppose I'm not going to spend a lot of time on dosing of those things, but you'll get more comfortable with it as time goes on. So when they're in the hospitals, they're improving, you could be more aggressive about adding things. But I think I would err on the side of a little bit too high, maybe less than 150, 140, but I wouldn't try and get it to 120 overnight. So calcium channel blockers. So this may be useful in people with cocaine or intolerant to beta blockers. And it kind of, so there's dihydropyridines and non-dihydropyridines. So if they're not tolerating beta blockers, diltiazem is probably a reasonable choice. And there's been some studies with that, even in MI, that may improve outcome. Those are all old. I don't know if people still believe them. So how much diltiazem would you use? And are you going to use long or short acting? Because they're going home on long acting if you use it. Someone look it up. Do you have your computer? Blood pressure is 180. Heart rate is 80. What? Who said 60? I use 60 as short acting. Short acting. Okay, good. All right, you make it a little less painful. But these are the kind of things that you're going to have an answer. You're there by yourself, and you have to find a way of looking into this. And a lot of this has to do with experience too. So you probably want to use short acting, because if something happens, then it's going to wear off quicker. So if you give them a big slug of the long acting, then that may be a problem. Verapamil is another option. So these you have to be careful, especially verapamil is a very strong negative inotrope. So if they have low EF, then that's not a good medicine to give. All right, and then you could use nitrates. So it's fine to see somebody on the floor and they're still having chest pain, and you give some sublingual nitroglycerin and kind of see what happens. Nitro paste, in my mind, is a little bit better than placebo, but it seems to work in some people. And then, but if you're really worried about ischemia, you put them on a drip. All right, so we'll finish up with a case. This was actually the case we had a couple of months ago. So 57-year-old lady, she's had sharp stabbing chest pain, recent viral URI kind of symptoms. She'd had it in the shower and it got better at rest, didn't get better with nitrates in the ER. So she has hypertension, hypothyroidism, history of asthma, smokes a pack a day, no family history, and those are the medicines she's on. So amlodipine and aspirin are the ones I care about. Then albuterol, MDI, which she just uses as needed. All right, so on exam, she came in, heart rate was in the 50s, blood pressure 175, pulse ox, the respiratory rate 22. That's abnormal. That seems to be kind of a thing at every hospital. They put these respiratory rates, and they'll count for like 5 seconds and 22. It was probably normal, really. But just keep in mind, when you're doing your HMP, if you're putting a respiratory rate of 22, that's not normal. All right, so physical exam really otherwise was unremarkable, and troponin is okay, and a little bit of high hemoglobin. All right, so what do you think? Here's the EKG. Low risk, high risk. So if you add all those things up, mean, she's not 65, she's a little bit old. High blood pressure, she smokes, no family history, probably kind of in the middle if you were to add all those things up, I suspect. So this is fine. This is your typical chest pain rule out and non-specific EKG changes. What about this EKG? Yeah, so this is a little bit. So B1, that's probably okay to have that, but you see the inferior, that's a little bit suspicious. You can't say that she does have some LDH, probably from her high blood pressure. So this is the usual thing that you do like 10 times a day on service, right? You put these people in, rule them out, send them home. So she had no chest pain. They thought it was pleuritic kind of chest pain from that viral syndrome, told her to take Mucinex and follow up with their PCP, which I think is appropriate. So she came back like the next day. I think I had the days mixed up on this. I didn't spend a lot of time doing this whole thing. So now she's got chest pain, pressure. Now she's got dyspnea and diaphoresis. Labs are still the same. So she goes to telemetry and she did okay for a little bit. Here's the EKG when she came back. Anything concerning on this one? So no ischemia probably. So you see these T-wave changes. I mean, this just may be for LDH. That probably looks about the same. These are upright now, which is a non-specific finding. Is that like pseudo normalization? I'm not sure. But so now she's back. Still having pain. And then somebody gets called because the pain is worse and you're thinking, you know, she was just here. What is she, crazy? She just had a cold. You've got 8 other things to do. And this is a case, the reason I bring this up is because you're thinking, you know what, she's probably crazy. I don't know why they keep admitting her. I'm tired of this. I've got other stuff to do. It's almost lunchtime. But fortunately, somebody went and saw her and got another EKG. All right. Sruji, tell me what you see here. Yeah, so this is inferior infarct. And this is high degree AV block also, and that just wasn't, and this is kind of, and I don't know, I'd leave this up here uncorrected for a couple of reasons. So you'll see, you can look at the top of the EKG, that's fine. Because it's, you know, it's not an EKG test every time you see these. Use all the information you can. It's there. It's like, you know, all of these patients you admit, it's like an open book test. I mean, you can do it if you need resources. There's things you can look at, and there's nothing wrong with that. And then as you get more experience, you won't need to as much. So I don't know how this got interpreted like that, but where are the P weights on this thing? So either that's a really long first degree AV block, or it's probably third degree heart block with a junctional escape rhythm. So I don't know if it's been interrupted or sometimes these things are finger gets worked on the thing deciding you can maybe that's what it is too. So that's not, it's a junctional escape rhythm, that part's okay. She does have LDH. She has high degree heart block. All right. Yes, that is a good point. So it's inferior infarct. So I would shy away from nitrates because they're going to be payload dependent, so you get fluid. All right, so now you're by yourself. You're up there seeing her. Now she looks terrible. She thinks she's good, and she is trying to die on you. Look at that EKG. So blood pressure now is less than 80, heart rate's 38. She's anxious, diaphoretic. Doctor, help me. You got to do something. What are you going to do? Now's the time don't waste time. You need to do something quick or she will die. You're a doctor now, all you guys. So aspirin, she already had aspirin. She's had Lovenox or heparin. Hopefully she hasn't had too much beta blocker. I would not do that. That's not your first thing. What's your first thing? She looks terrible. So heart rate, okay, that's not, that probably should be addressed. Atropine, you can try that. It's not going to work. That does nothing. What's the first thing you want to do? Besides get help. So now's when you took the time, you'll call your senior. So this is, she needs something very quick. That's what they, that was in the, so it's probably. So I mean, yeah, you could get fluid. You can, so yeah, you can use a transcutaneous pacer, that's fine. That will be okay. That's kind of barbaric, but so you'll see what happens when you do that. But that's okay, because you know what? I would be nervous here. So I mean, you give her fluid, you could put her on something for a heart rate, right? So this is one of the few times you might think of maybe dopamine might be okay, because that will increase the heart rate, or you could use norepinephrine, would be a good choice. But definitely, whatever fluid they have, you have it wide open. You want to get normal saline, and you can have them hang some kind of pressor. And so it'd be dopamine or norepinephrine. Usually they'll say just use norepinephrine. That's what the guidelines will say. But sometimes dopamine, I find, will increase the heart rate a little bit more. And you can have the backup pacing. Now what else? So you need to call somebody. So call your senior, call a cardiology fellow. This is not somebody, don't mess around. It's not time to take lunch. Not time to sit and, I mean, you're going to be scared for sure, probably. But you need to do something quick, or because you don't have more than a few minutes to do something. All right, so they call the cardiology fellow, and I got this picture, and you can do that too. Take pictures of an EKG, and I suppose you better cover up the protected health, whatever. So cover up the name, and you can send EKG pictures of EKGs. And so I got this picture. All right, so now she's on the way to the cath lab, and this happened. True story. She was actually in the cath lab. What do you do? She's dying. Compressions. Okay, what else? Huh? Monitor's on. That's how you found this. Exactly, right. So shocker. So she got shocked a couple times. They got some CPR. They got a perfusing rhythm, but that's a little bit scary, even for me. Usually when you see those, it's not a good way to start a case, even with step. All right, so that's so good thinking, but you have to be able to make quick decisions, and it's not going to be easy for a while or ever. So cardiologists like pictures, and this is kind of, this is what we saw. So this is the right coronary artery here. And so I didn't miss the 3rd-degree heart block. This is a pacemaker. So that's what we start with. So what we do is put a wire down here, and it's just kind of like a central line. Over the wire, we put balloons. And so this is a balloon here. It's kind of hard to see. The problem is there's clot and everything else. When you see a balloon up and there's dye distal to it, it's usually not a good sign. It's from bad flow. So we're able to get reasonably good flow, and you see this long area of disease here. So this is a stent that's wrapped around that balloon. So we expand that stent, and that gets opposed to the vessel wall, and that's what we end up with. And so actually, she did very well. We're going to intubate her, but she kind of woke up after getting shocked and CPR a little bit. So she did fine. And I think the key is here, somebody was up there, somebody actually took this seriously, went and saw her and got things moving relatively quickly. And it's not going to seem like it moves that long, because they will call the cath lab in. They're not here for half an hour, and then it takes them another 20 minutes or more to set everything up. And so someone has to sit with her on the floor at some point. If you have, yes. Yeah.
I didn't know if that was.
You are, but you have to perfuse. So if you have no blood pressure, then you're gonna perfuse and get arrhythmias and so it's better to have a heart that's still beating and ischemic than not beating, and you don't put them on anything. And it's just something that comes with experience too. So, but luckily someone paid attention and actually took care of the patient. And if they would have waited longer, she would have coded on the floor, and it's just a long drawn out thing. So the faster we can open this artery, the better. So just kind of general rules. Every one of these people, and this is kind of hard, and you need to be like this in your whole practice. I mean, you guys I'll tell you, I'll speak for myself. I practically begged to get into medical school. I asked for this stuff, and some days you're going to think, why did I want to do it? But you've asked for this and you've accepted this responsibility. It's not always easy to do the right thing by people, but you really need to treat everybody as if they're a member of your own family, and you probably won't go wrong. Now, I don't like everybody in my family, but it's cordial. So, but that comes with, what, you're eating lunch and somebody calls and there's problems, and it could be serious. Really, you owe it to the patient to go see them. I can't tell you how many times I drug myself out of bed at 2 in the morning when it's 20 below out to go see someone because something didn't make sense. All right, so don't miss PE, MI, or aortic dissection. So also use your resources. So you guys are, you're going to feel alone sometimes, especially at night. There's nobody there. If there are other people, if you have other interns, sometimes it's okay if it's not serious and you don't want to, you think that your senior is going to yell at you or think you're an idiot. I mean, you'll learn as much from your peers as you will from everybody else. But definitely use, there's somebody here all night. There's a second or third year, so you can definitely discuss things with them. If you need to, call the cardiology fellow. It's not a problem. Those guys are here for you. One thing I would ask is that, those guys, it's a little bit different for them. They're working their whole day, so the service for them is a tough month. So he's here all day. Then he's on call every night from Monday to Thursday. And then even the weekend guys are on Friday, Saturday, Sunday. So they don't get a break. So try and, if you can, use your seniors. But if you need to, then call them, and I would expect that they would be responsive and definitely help. Now, if you had something where maybe you call the fellow and this EKG, you think there's this, I've seen this before, anterior ST elevation, and the cardiology fellow said, nope, it's early repolarization, leave me alone, and want to sleep all night. And then someone comes in the next day and like, oh my God, what do we have? And occluded LAD. So if you didn't think there's always a cardiology attending on call, if you felt like you have to, that's okay. I don't anticipate that, but certainly that option is there. Keep in mind, you're going to make mistakes. No one's perfect, and nobody expects you guys to know everything. Things are going to happen, and you're going to have people that you will probably kill a couple of people. Someone's going to die because you don't do something correctly. But you want to minimize that. And one thing also, not only are you going to learn from your own, I could tell you a lot of the mistakes I've made my whole career. Some of the stuff you think, God, what was I thinking? Why did I do whatever? And you guys will all have those kind of thoughts. But in training, it's great. Or even actually in real life too, you see this. Look and see what happened when someone else had a bad outcome. Learn from someone else's mistakes, and that's a lot easier because then it's not you exactly, but those are all beneficial. All right, so we're a little bit over. Any questions? All right, good.
Yes, I did.